This is Dr. Chuck Murphy, and I'm here at the Inova Heart Recovery Symposium, and I'm joined by Dr. Bill O'Neill from Detroit. Dr. O'Neill, I'm thrilled to have you here, and I'd really like to have you just share with us some of the really tremendous work that you've done in the area of cardiogenic shock.
Sure, Chuck. Well, in 1980, when a patient came into hospital with cardiogenic shock, they had a 90% mortality. And in the mid-'80s, we started doing emergency angioplasty for treating heart attack. And along the way, we started treating patients with cardiogenic shock. And we realized very early that you could dramatically improve the survival. So at the University of Michigan in 1987, we published our first work on angioplasty and treatment of shock. And we found that the mortality increased from, the mortality decreased from 90% to 50%. So dramatic improvement in survival. But that hasn't changed in 30 years. At the TCT Symposium that was just done, the latest large European study of angioplasty and shock showed that still a 50% 30-day mortality. So we've got to do something different, and that's really what drove us in Detroit to try to figure out a different way of treating the shock patients using initially very early use of hemodynamic support followed by angioplasty, and we've now been able to show an improvement in survival to 80% in the most recent series. So we've taken the mortality from 50% and dropped it to 20%, and I think that's going to be a huge advance in Detroit with all the hospitals collaborating, and I'm hoping that we can replicate this on a nationwide basis.
You know, it's interesting because I'm a heart surgeon by training, and of course, we always tried to get the patient on cardiopulmonary bypass as quickly as possible, and then we would go on to perform the coronary bypass grafting. So in a sense, it's a similar model of getting to unloading as quickly as possible.
It's both unloading to preserve myocardium, but it's also to provide blood to the tissues. I mean, the sine qua non of shock is that there's not enough forward cardiac power to provide perfusion to extremities. And so it's really disheartening. You take a patient to the cath lab, you do an angioplasty, you put a balloon pump in, and then there's something that gives out. Their liver dies, their kidneys die, their bowels die, some end organ becomes catastrophically fatal, and more than often than not, the mode of death in these shock patients is non-cardiac. It's bowel ischemia, infarction, liver failure, renal failure, and it's all because the extremities and the organs have not been adequately perfused. So you've got to get forward power to perfuse the extremities, and at the same time you want to try to preserve myocardial function by offloading the ventricle early.
And if we can avoid that multi-system organ failure, with the technology and the advances we've had in other fields, then there are other options for that patient that just has cardiac dysfunction.
Well, I'm really excited about the opportunity here at Inova because I think your health system is uniquely poised. Of all the health systems I've seen in the United States, I think this system, with the great talent that's available amongst interventionalists, with the wonderful surgical group, with the VAD and the transplant group, you guys can sort of organize a tiered approach where you're out in the field and resuscitating the patients quickly, and then if they need escalating the care to anything like surgical VADs or even later on the road heart transplant. So I think that my hope and aim is to kind of help you guys to demonstrate to the world what the best results, and I'm convinced that we can get survival up to 95% in cardiogenic shock.
Wow. Well, Dr. O'Neill, thank you very much, and it's really an honor to have you here.
Thank you, Chuck.